Well, good morning, good afternoon, good late night, good evening, wherever you are located in the world. About half of our folks are outside of the U.S. We are a U.S. Channel, but we're saving lives throughout the world, and we're very excited. That makes it all worthwhile. Today, we're going to be talking about new criteria for diabetes and prediabetes. Um, you know, Before I start, I have to say we're a couple of minutes late because we had some technical difficulties. People say, "Well, hey doc, you shouldn't talk about technical difficulties if you do a lot of telemedicine." You know, these things happen to anybody and everybody. We got ready to start this morning, and Chrome had decided that it couldn't share our screen. We've got some good information on our deck that we'd like to share with you. And so we had to get it set up. Now to the topic for today. Here's the thing. You've heard me say this multiple times before. What about diabetes and prediabetes? Should we just get rid of the term prediabetes? Because, you hear it all the time. Well, my doc said, I've just got a touch of sugar. Well, if your doc says, I've just got a touch of sugar, be afraid. Be very, very afraid. And you know what? Guess what? I'm not the only person saying that anymore. We've found an article where other scientists are requesting the same thing. We're going to cover that article today when we get to the content. But first, just a couple of other comments about what we offer. We're all about saving lives, helping people understand that there is one root cause behind heart attack, the number one cause of death, stroke, the number one cause of disability, blindness, kidney disease. All of these things come back to what we're talking about today. Diabetes and undiagnosed prediabetes. Even the CDC, as conservative as they are, will say, look, 90%, 9 out of 10 people that have prediabetes don't know it. And as you'll find in the discussion today, and we'll cover a little bit more of it later, prediabetes causes the same kind of damage that diabetes does. In fact, by the time people get a diagnosis of type 2 diabetes, between 1 and 2/3 already have damage to their eyes and damage to their nerves. So again, we'll talk about it as we get a little bit more into the content. Topics that we've covered recently, the problems behind cardiovascular testing. One of the big issues is just the cost. Another issue is radiation. But by far, the biggest issue is what happened to Tim Russert. He had his stress test. He thought he was fine, and he died a few weeks later. Statins and cardiovascular inflammation, the real impact on plaque. What do statins actually do? Anything? Do they just make your muscles sore? Do they just cause other problems? Or do they actually have an impact on plaque in your arteries? That's we cover that the other day. And do statins decrease inflammation? So that's the kind of content that you'll see from our channel. If you've not been here, if you've not seen our channel before, what we do is help people understand the information that they're just not likely to get from their doctor. The science is pretty clear. 2/3 of primary care doctors, and that's here in the United States with supposedly one of the best healthcare systems in the world. 2/3 of primary care doctors don't know how to diagnose prediabetes, let alone manage it. Let me repeat that. Here in the United States, where we're supposed to have a great healthcare system, one of the best in the world, 2/3 of primary care doctors that are seeing patients don't know how to diagnose the root cause of heart attack, stroke, blindness, kidney disease. They don't know how to diagnose it, let alone treat it. So unfortunately, it sounds like markets, caveat emptor, buyer beware. patient beware. Now, there's some solutions, and that's what we do. We provide those solutions with courses. These courses are cheap and easy. Sometimes we offer them for free. Quite often we do. At most we've charged, I think, $40 $40 and a couple of hours. You can know more about how to protect your health and have 1, 2, 3, 4 more decades of healthy life. You can know more about that than your doctor knows. So, Jubilee, as I said, we have been very pleasantly surprised, very excited. We continue to do a lot more work because there's just so much interest and such a good reception to our programs here in Lower Alabama. And it used to be Lower Alabama, LA, the other LA. But now it's not even just Lower Alabama, it's Central and Northern Alabama as well. We've got clinics coming up in a few weeks in Center Alabama. We're continuing to add more docs, more senior NPs to the program here in Baldwin County, Mobile. James is meeting today with a very senior doc in this region who's very excited about coming on board as well. That doc has a lot of interest, just like I do, in the number one cause of heart attack, stroke, and blindness and diabetes. That's what's killing us. That's what's disabling us. And we're setting up real programs to deal with real people, and they're loving it. So the book, Prevention Myths, What to Do About It. This is the big one that we've got so far is how to deal with stress tests. Hey, doc, my brother just had a heart attack. In fact, I had a patient come in and see me yesterday because his brother just had a devastating heart attack and is in the ICU, and he's been in the ICU for several days. They're not sure. They think he's not going to live. And that patient's brother was a smoker. The patient himself has some issues with diabetes. Again, don't let your doc say, hey, look, I think you got a touch of sugar, and let's just check it next time. If you've got a touch of sugar, be afraid. Be very afraid. But know this, that you can take that risk entirely off the table. So why are we so focused on getting rid of the diagnosis of prediabetes, a touch of sugar? Gilbert, if you'll give us the water ball, we'll get into that content. So, new criteria for diabetes and prediabetes. Basically, what we're suggesting and what he is the same thing that this author is suggesting. Get rid of the term prediabetes. This was an article in Cell Press. The time is now for lower diabetes diagnostics and thresholds, trends in endocrinology and metabolism. And here's what they're saying. The current thresholds for diagnosing diabetes were set more than 2 decades ago, back in 1997. The actual evidence suggests intervening earlier along the disease continuum. In other words, you get disease earlier, way before you get a diagnosis of full-blown diabetes. So the goal is to mitigate transition into frank diabetes. And most of all, it's not really a question about preventing further diabetes. It's a question about preventing cardiovascular disease, and to delay and reduce and take those risks off the table. The fact that prediabetes is associated with micro and macro vascular complications, in other words, cardiovascular disease, eye vascular disease, kidney vascular disease is almost as important as the number who will progress to full-blown diabetes. In fact, that's the author's perspective. I will tell you this, it's far more important. What happens to the heart, the brain, the eyes, the kidneys is far more important than whether they go on to develop full-blown diabetes. In fact, if you looked at the current trend, diabetes medications, if a new diabetes medication that comes out, they don't really look quite so much at what it does to the diabetes. They look at what we call CVOT, cardiovascular outcome trials. The quality, the value of a diabetes drug is now measured by the impact it has on vascular disease. So back to the article and the script, a new diagnostic criteria for diabetes is proposed to improve the patient's long-term health status. Before I go to the next slide, I'll make another comment about CVOTs, cardiovascular outcome trials. A big one just came up for Farxiga. I think it's dapagliflozin. It's one of the SGLT2s. Just over the past 6 months, blockbuster information has started coming out about those drugs. The GLP-1s also coming out with great cardiovascular outcome trials, cardiovascular results. I've been clarifying that for my patients, but I still get a lot of hesitation, and here's why. The SGLT2s are like $600 a month, and the GLP-1s are about $1,000 a month. They're very expensive. And insurance companies aren't really covering it in these early phases. But we'll talk about that at a later date. Let's get back to the script, back to the article and the diagram. As you see, look at this image on the right. This author is suggesting exactly what I've been suggesting. Get rid of the diagnosis of, quote, prediabetes, metabolic syndrome. All of these diagnoses that tell the patient, well, be careful because you might get sick. No, you are already sick. Back to the text. Hyperglycemia alone does not define diabetes. That author knows, as do we. Diabetes is a complex series of metabolic derangements. It includes hyperinsulinemia and or autoimmune inflammatory mechanisms. In other words, the inflammation, the cardiovascular inflammation, attacking the plaque in your arteries. The proposal that this author has is including abnormal glucose and glucose tolerance with the disease of diabetes and permanently remove the concept of prediabetes. It's an artificial distinction between prediabetes and diabetes. The pathophysiology, that sounds like a really big, complicated word. Patho means pathos, damage, bad stuff. And physiology is how that works. So the point is how prediabetes creates disease and destruction of tissue is the exact same way that diabetes creates destruction of tissue. It's the same disease. The difference between the two is artificial. The pathophysiology is insulin resistance. The receptors lose their ability to respond to insulin. You get impaired incretin action, one of the other hormonal components, insulin hypersecretion. So because the insulin receptors are not responding to the insulin, the brain, there are cells in the brain that read the level of sugar, of glucose in the blood, and they go to the pancreas and say, put out more insulin. Too much secretion of insulin. Increased lipolysis. So again, we're not going to go into that, but we will say ectopic lipid storage. In other words, storing fats because you can't burn them, because you've got too much insulin out there. One thing that people don't know, most people think that insulin basically is supposed to pull sugar out of the blood into the muscle and liver. That's very true. That is the number one function of insulin. But insulin has a couple of other functions as well. The first one being it's actually involved in memory, the development of memory. So there's a mysterious connection there, couple of connections to Alzheimer's. But the other one that most people don't know is that insulin stops the body from burning fat. And that's why you start getting this ectopic or extra places of lipid or fat storage. Now, complications of prediabetes, they're the same as complications of diabetes because, again, it's the same disease, the same pathophysiology. Although diagnostic thresholds were in part informed by epidemiological studies in the 90s. In other words, what does that mean? That means that, back in the 90s, they said, well, when people have prediabetes, we're not seeing a lot of damage. Well, that was wrong. There's new epidemiology out there. It's really clear. Diabetic retinopathy, in this article, they say 8 to 12%. I've got other articles that say between 1 and 2/3. Diabetic retinopathy has occurred already between 1 and 2/3 of people by the time they get a diagnosis of full diabetes. Retinopathy, neuropathy, damage to nerves, and nephropathy, damage to kidneys. All these occur at substantive rates within patients classified as pre-diabetic. Again, in this article, they're saying between 11 and 25%. Again, other articles would indicate 1 to 2/3 of patients. Now, why are we just discovering this? Because we're just looking, and we have ways of seeing more subtle damage in these areas that we just couldn't see 30 years ago. Hyperglycemia, too high blood glucose, has been associated with accelerated cognitive decline. In other words, yes, even Alzheimer's starts happening in prediabetes. So other dangers of prediabetes, the dysglycemia, another technical term, dys just means messed up. So glycose means glucose, emia means blood. So pre-diabetic abnormal blood glucose increases the risk of cardiovascular disease, heart attacks, congestive heart failure, coronary artery disease, atherosclerosis, stroke, peripheral artery disease, cardiovascular death, kidney disease, eye disease. Again, I think you're getting the message, and pardon me for all that repetition. Many pre-diabetic patients live with concomitant risk factors such as insulin resistance, obesity, metabolic syndrome. And again, there's a great book by a fellow named Gary Taubes, Taubs. It's called Why We Get Fat and What to Do About It. It was a big New York Times bestseller. It was so popular, he wrote another book about the same topic that was about twice as long. It was called Good Calories, Bad Calories. Now, why did I bring that up? Because of the point that that this last bullet is making. He makes the point that he's talking about why we get fat, and he said, well, we tend to get heavier when we're in middle aged, and people think we get heavier because we're eating more. He talks about the hormones like insulin and what's actually going on there. And he makes the point that because we are getting insulin resistant, our insulin levels are going up. Because our insulin levels are going up, we can't burn fat. So that fat, instead of burning it and using it for fuel, it just sits there and it grows and it grows and it grows. So in reality, it's not that we get fat because we eat more. It's that we eat more because we're getting fat. In other words, we're eating fat. We eat more because we're hungry, because we can't burn the energy in the fat that we have eaten. So gives you a little bit different perspective and turns that concept on its head. So back to another article in this space, treatment and conclusions. Treatment of prediabetes should include diet, lifestyle modifications, and even anti-diabetic agents. As you know, I've offered metformin for years, long before people get full diabetes. We're getting to points where some folks are saying, you know what, I'd like to consider the SGLT2s or even the GLP-1s before we have I get full-blown diabetes. And in fact, I did a couple of videos on Victoza, one of the GLP-1s, for weight loss. The GLP-1s, Ozempic is one of them that you probably have heard of. Those are given routinely for weight loss. Back to the script. The Stop Diabetes trial highlights the potential of combination therapy designed to correct underlying, again, pathophysiologies, although the research regarding complications is limited. So again, there's not enough research yet to demonstrate all of the improvements that we expect to get when we start getting more aggressive about treating prediabetes. The authors state they're not advocating for pharmacological intervention on early diagnosis. I would say what I've always said. This is a lifestyle issue. The lifestyle is important. You cannot out-prescribe a lifestyle problem, but prescriptions sometimes help. Excuse me. So that's it for the content for today. Pardon me if we were a little bit repetitive, maybe a little bit overpassionate, but this is killing people. So, Gilbert, if you'll give us the transition, we'll go into Q&A. So there we go. Oh, we've already got, oh gosh, we've got a lot of folks here today, over 100. John Tocho, good morning. Robert Weiss from the North Georgia Mountains. Robert Weiss saw a video on triglyceride over HDL, included exercise level and levels of the ratio of exercise. Probabilities of cardiac issues went up as the ratio got larger and the exercise level went down. Absolutely. Dennis Bolaños, can metformin prevent type 2 diabetes? Metformin helps. There's actually a head-to-head clinical trial published in the New England Journal about 7, 8, maybe at this point 10 years ago. Here's what they did on that head-to-head trial. They said metformin in one group and just a very mild lifestyle intervention, getting people to walk a little bit more, teaching people a little bit about their diet, their lifestyle. Folks lost an average of about 5 pounds. It wasn't a whole lot. That intervention was 3 times more powerful than metformin alone on preventing type 2 diabetes. So again, it's a lifestyle issue. B. Flint, good morning. Back to that question again. I offer metformin and actually recommended it as soon as you get a diagnosis of prediabetes. The other thing I'll let you know is that we have a routine program. It's done in webinar format. We offer testing and diagnosis for prediabetes. We had one, I think it was earlier this week, and one of the patients had been asking her doc about this. She began to worry about it. She came back with blood sugars at 1 hour of 270. So again, there's a lot of us out there with prediabetes and like that person, full-blown diabetes. And not even if you find people like that all the time, even though they suspect it, they have some interest. They've done some finger stick testing. Their doc doesn't want to do the testing and diagnosis. It's just, if you're reading some emotion and frustration here, yes, you're reading me correctly. Good morning, B. Flint. How are you today? Rachel Weinstein. Hello, everybody. Yalish Anand. Have PP level 634 diagnosed yesterday. Not sure what that means, Yadish PP. Parker Reed at Bolaños, you prevent and control type 2 diabetes through diet and exercise. Type 2 diabetes for the majority of people is self-induced. It's not completely self-induced, but we clearly, as individuals, have the keys to take that off the table. Francis Nance, good morning from California. On keto to keep carbs low. Does saturated fat in whipping cream or cheese or meat cause other issues? It's a great question, Francis. There's an article called, or a book. Somebody help me out and remind me of the name. Nina Teicholz. It's a great book. It's called The Big Fat Surprise. And she goes into the details of how fat has been demonized and the facts that saturated fat's not as bad as you think. At least that's her position in the book. Now, it's very interesting. The American Heart Association and a couple of other groups, the American Cardiology, College of Cardiology, ACC, just published last year or the year before a series of articles, including a meta-analysis. A meta-analysis means the researchers looked at every article in this space. And their perspective was saturated fat does not cause health damage. That's a big surprise. And a whole lot of plant-based diet fans really hate hearing that, but it's the reality. People ask me quite often, okay, doc, well, so which diet do you go for? There's the biggest rule that I have about diets. I don't really care quite so much whether it's keto, paleo, plant-based, vegan. What's the other one where you just, carnivore. Here's my issue. Start with understanding the situation. If you cannot metabolize carbs, if they're damaging you when you eat them, then don't eat them. So my focus is know if you have prediabetes. If you have prediabetes, no matter which of those diets you use, just limit your carbs. Dennis Bolaños, Parker Reed, thanks. PT Health from Irvine, California. Thank you, PT. I appreciate that. Craig Bax. Good morning, Dr. Bax. Good to hear from you. Parker Reed, a super chat for $10. Thank you so much, Parker. Again, our co-host today, Gilbert, and our usual co-host, lives in the Philippines. $10 US may not sound like a whole lot, but it's a big deal in the Filipino economy. And I usually support the channel with my efforts and my savings, the proceeds from seeing patients. And Parker, you just helped us get this message out and save lives all over the world. Tired looking for name, $20 super chat. Thank you so much. And Gilbert is showing you how to do a super chat right in the upper right-hand corner if you'd like to do that yourself and help us save lives. Don Stewart, triglyceride HDL ratio is 2.5. I would have a goal of getting it a little bit better. A1C is 5.2. I do keto and exercise. What do I need to do to get this lower? Triglycerides are 102, HDL is 41. That ratio indicates that you've got some inherent problems in your glucose metabolism. If you're on keto and you're actually ketotic, then you're doing what you need to do in terms of keeping carbs out of your diet. But as you see, Don, that may not be it. That may not be everything you need to do. And it's true. Body fat drives this problem. So I see so many people with keto that still have a significant amount of body fat. And so the other thing that drives it is getting older. Well, getting older is not a great option, but there are options. Continue to push on the amount of body fat that you have. The second option, muscle mass. muscle mass tends to decrease as we get older beyond the third decade, our 20s. But it really starts to fall off a cliff in the mid-60s. And it's one of the key drivers of cardiovascular inflammation and death and disability is loss of muscle mass. So one of the things that I tell my folks, especially those of us hitting our 60s and getting older, start working on that muscle mass. Get the resistance training that you need to do. Parker Reed, hey folks, let's support Dr. Brewer's channel. This is not a freebie, so please show your appreciation for the great information. Thank you so much, Parker. I do appreciate that. And Gilbert has given you a link where you can go look at some more information if you're interested in the information that we provide with the channel. Brendan Lenane, good to see you, Brendan. Crestor insert advises not to use with nicotinic acid as it can cause serious side effects. What effects? My A1C has gone from 5.2 to 5.6 since using both. Niacin 500 and Crestor 5 milligrams alternate days. Great question, Brendan. And here's the issue. Both of those. Nicotinic acid, by the way, for those of you that don't know, is niacin. And Crestor, most of you should know that that's a statin. So both statins and niacin have a side effect of increasing insulin resistance. And that's typical, what you've just described there, Brendan. Now, a lot of people say, well, therefore, I don't want to take a statin or I don't want to take a niacin. I don't recommend people take a statin or niacin unless they really need it. Now, when do I recommend a statin? If you have plaque, if your body has already formed plaque in the artery wall. At that point, it's really clear. You're struggling, your body's struggling, it's making plaque, and it's now at risk for, heart attack and stroke. When do I recommend niacin? I've got a whole series, over a dozen videos on niacin. The niacin's a big debate. There's several issues with it. I remember taking my first few trials of niacin back in my 40s. And I was in church one day and I had taken the niacin a couple hours beforehand. I felt like somebody was scalping me, just taking my whole scalp. And that's what happens. Niacin has a reputation for causing, for causing flushing. It does that due to a thing called a prostaglandin. We're not going to get into the technical stuff on that. But so here's what happened. At that point in time, and it still does, niacin has a great reputation for doing several very positive things. We've talked about the insulin resistance. We've talked about the flushing, but here's what we didn't talk about. Niacin is the only thing that increases HDL, decreases LDL, decreases triglycerides, and tends to decrease LP(a). And if you don't know about LP(a), you can ask us about that a little bit later. So there's very positive things that come out of it. Now, other folks would say, and a lot of docs feel like, oh no, that was disproven. Here's how and why that was disproven. There was a trial called the HPS2 Thrive trial. I think that was the one where they put lapropiant that may have been another one, but they put lapropiant, I think it was Pfizer that did this, put lapropiant in niacin. Now, why would they do that? The lapropiant stops that flushing that you get with niacin. What they found was that did not work. Niacin didn't work at that point in that trial. So they threw the baby out with the bathwater, if you know what I mean. If you're from the deep South like I am, the phrase throwing the baby out with the bathwater means basically, you made some changes. You maybe have got rid of some bad stuff, but you got rid of the good stuff as well. And that's exactly what happens with lapropiant. The chemical additives to, quote, non-flush niacin tend to also make niacin where it doesn't work. So there are some ways to get niacin. There are a couple of ways that, supplements that I've used, Rugby brand niacin and Enduracin. My patients have tolerated Enduracin far better. Now, again, one thing that we haven't talked about, a final thing that we haven't talked about with niacin is it can also cause liver damage. So you get a lot of good things from it. There's a lot of stuff on the internet about it. But, you know, just like anything else, don't take it if you don't need it. So went down the niacin bunny trail. Won't go down the statin bunny trail right now, unless we get more comments about it. Fort Worth West Side. Too bad this topic is not addressed more heavily in public service announcements on TV. Of course, the food industry would likely downplay or outright oppose a great deal of that effort. You bet. Iwando Megales. Good to see you, Iwandro. Hi, Dr. Brewer. Greetings from New York City. Greetings to you, Iwandro. Good to hear from you. Thank you very much for commenting. Parker Reed, located over the west side of the Metroplex. Looking forward to another round of ice. TD. Thanks, Dr. Brewer. Jose Fontal. Hi, Doc. Any thoughts on nattokinase? I've been able to cut down from my losartan dose in half since I started taking it, and the blood pressure's been great. Nattokinase, or natto, is a powder that's made from usually fermented beans, and it has K2 in it, and I do take that every day, and a natto powder that I get on Amazon in my coffee. What's the story on K2? I've got about a half dozen videos on that. One of them's not the greatest. It gets a little bit confusing, but the bottom line is there's evidence that K2 actually helps us with this root cause problem of prediabetes. TD, 2 medical oncologists, 2 medial oncologists, and a radiation oncologist told me insulin is not a growth hormone. Well, that just goes to show that primary care doctors don't have a corner on the market of not understanding diabetes. It's frustrating and it's true. In fact, specialists understand diabetes for the most part less than primary care docs, if you can imagine that. Parker Reed, Dr. Ben Bigman posted the lab studies validating this via tissue samples combined with diet studies. Thanks, Parker. Sima Basavan. Hello, Dr. Brewer. I've had severe complications in my health. Thalassemia, heterozygous, hyperthyroidism, age 36. TIA, transient ischemic attack. That's like a non-permanent strokes. Now cardiovascular retinal occlusion, right eye, having a Vastine injection. Oh my goodness. Thanks for sharing, Simria. And you can't change thalassemia. So what people, those of you who may be watching would say, well, what is thalassemia? It's a variation in the genetics of hemoglobin, blood genetics. Most of those, thalassemia, sickle cell trait, and another one called haptoglobin, all tended to be concentrated around the malaria belt of the world. And all of them tend to have problems. So why did they increase from the original mutation? Because they protected from malaria. So hang in there, Simra. Obviously, you can't change that much about thalassemia, but there's a lot you can do for the rest of the situation. TD, thanks, I liked it. Brendan Lenane, I called vasopressin being promoted as a memory enhancer in the 90s. I don't recall that. Fort Worth West Side, is there a procedure available where insulin-producing cells can be successfully transplanted to the pancreas from someone else? They've tried those. They haven't been able to get them to work yet. One of the things that, if you look at some of Walter Longo's work, he saw some increased development of those islets of Langerhans, those insulin cells, based on different types of fasting. So there's a big opportunity with fasting that most people are missing out on. Ewandro, Dr. Brewer, can keto or IF, intermittent fasting, cause copper deficiency? I have not seen a significant problem with copper deficiency resulting from lowering your carbs. Ewandro, thanks. Margaret D, hit the like button, please. Thank you, Margaret. I appreciate that. Rich D, 5 years after a quadruple bypass. That's what CABG means. You'll hear doctors talk about CABG, C-A-B-G, coronary artery bypass graft. Regular exercise, now diagnosed with claudication, another technical term. That just means you go walking and you get some cramping in your calves because your blood supply is not so good. You've got plaque in those leg muscles. Is medication needed? Well, it depends. That depends. Crestor does not seem to be helping. It's not going to reverse claudication. Metoprolol, that's a beta blocker, is not working. That, I wouldn't try that either. I mean, you might try that, but back at square one. This, like heart failure, like prediabetes, one of the most effective, important things is to look at lifestyle. Look at continued walking. Clearly don't stop the exercise, even if you're getting the claudication. Thanks for sharing that, Rich. Aura Ruth, Kamieni. Good to see you, Aura Ruth. Hubby's listening too. Well, I'm glad to hear that. I'm glad you got him in. Raymond Rogers, I've not been able to control my sugar. My morning sugar is 130 or higher. By the way, 125 is one of the criteria for full diabetes. My A1C is 6.2. I take metformin and been watching what I eat. Should I go see an endocrinologist and take insulin? Well, number one, so if you look in the U.S., and the U.S. again has more specialists than any other country, endocrinologists, there's enough endocrinologists to deal with about 10% of the diabetes that's out there. So you'll have a hard time getting an appointment. That's also the case with things like psychiatry. There's enough psychiatrists out there to deal with about 10% of the psychiatric mental health issues. And you see that with specialty after specialty. Now, as I've mentioned before here, there's a lot of stuff that's known and very, very clear about what to do for full-blown diabetes. My patients, for example, about 1 out of every 5 of my patients is full-blown diabetic. And we're involved on helping get them where they need to be. If you'd like to see me, Gilbert, if you'll flash up Michelle's number, 859-721-1414. That's 859-721-1414. We're really slowing down on my slots, Raymond, but usually, especially with somebody that's got some specific challenges and needs help getting started, we'll usually be able to work folks in. Ewandro, my neutrophil count is borderline, going to low carb. That's not really, especially borderline, that's not really an issue. And in fact, it sometimes indicates decreased inflammation. Am I doing anything wrong? No, you're not doing anything wrong. What I'm hearing from this part at all. Should I reduce the IF window or maybe just 12 hours? No, I think the lower windows are better. 16 hours fasting. 8 hours of eating, or 20 hours of fasting. So there you go. Steve Birch at Raymond. Type 2 is a disease of the, can't read it, for the FERC, for abnormal 90% of us. Sorry, Steve, couldn't get that. Fork. Oh, a disease for the fork. Absolutely. That's exactly right. Love Nina Teichholz. Yep. Blade Runner. What do you think of the strict carnivore diet for prediabetes? I mean, only beef and salt, nothing more. You know, we've got docs like Greg Bax watching, and I raised that on a recent video where I said, I thought that was the cookiest diet I'd ever heard of. And then I started hearing more and more about it, and I started researching it. I still think, just like many diets, it has its issues. Like vegan diets have issues with some of the vitamins. Well, this diet has got some issues as well. But the bottom line, is it totally crazy? The Inuits, the Eskimos lived on a carnivore diet for generations. And guess what? Those generations didn't have cardiovascular disease. So I'll get back to it. You need your things like vitamins. You need the energy to live on. And most of us, especially after age 30, need to start watching our carbs and decreasing those carbs. Those are the things that you need to do with a diet. How you do that, whether that's vegan, plant-based, keto, and I mentioned carnivore, which would just drive most prevention docs crazy. How you do that is really more up to you than my concern about prevention. Vijaya Akar, does taking T3 medication cause high insulin and insulin resistance and inflammation? No, in fact, one of the bigger challenges associated with getting diabetes is the fact that many people, as we get older, begin to lose our thyroid hormone. And that's what he's talking about, thyroid hormone. Jonathan Hull, good morning, Dr. Brewer. When you treat patients remotely, how do you cooperate with their PCP? Do you take care of cholesterol and blood sugar, and the PCP takes care of anything else? So what I do is I take care of the patient, and that involves anything and everything. Now, one of the questions is, well, are you licensed in my state? I'm licensed in about 48 states. I think it does not include Hawaii. I know we just recently got a license for Alaska. Now, how I coordinate with the doc is really more a function of the patient. The patient is the executive. I'm a consultant. And they usually come to me for, reasons reasons like their doc not being totally up to speed on what to do for these items. I have and will routinely be happy to talk to doctors to help get them where they need to be. Some doctors are very, very receptive. In fact, after a few minutes, most doctors are very receptive. Some are not. So again, the patient is the executive, makes the decisions. I just provide the information and scripts if they need it, prescriptions. Bobby Ocampo, good morning, and from the Philippines. Francis Nance, thank you. Appreciate that, Francis. Ann W., hello from Kenya. And I think I know you're the first person I remember calling in or writing in from Kenya. Thank you so much for letting me know. My mom has been diabetic for a decade. Now she's experiencing neurological issues, loss of balance, coordination while walking. She's been diagnosed with mild aortic stenosis. Thank you so much for sharing that, Ann. I appreciate that. Iwandro, $20 super chat. Thank you so much, Iwandro. We appreciate that. Bobby Ocampo, ask Gilbert to like, subscribe. Gilbert, if you would, show folks how to like and subscribe. Thank you so much. Peter Von Loan, another $20 super chat. Guys, I do appreciate this. This is so helpful in terms of helping us get that information out there. Jonathan Hull, 1999. God bless you and your team. Thank you, Jonathan. Marwan Saw, A1C, is it still a good test for diabetes and prediabetes? It's a good test. I use it a lot, but it's extremely unfortunate because most doctors think that is how you make a diagnosis of diabetes. And you can see it all the time. And even here in America, so in the US, they say, well, that is the definitive diagnosis. No, stop. I've got a slide, and we've covered it on a few different videos. The AACE, American Association of Clinical Endocrinologists, has said this: don't use A1C to make a diagnosis of diabetes because it involves hemoglobin as well as glucose levels. Anything that changes your hemoglobin can change your A1C. And that would be genetics. The genetics of hemoglobin. We talked about that already. We've already had one viewer talk about thalassemia with genetics of hemoglobin, kidney disease, liver disease, pregnancy. There's so many things that can cause changes in A1C. Now, here's another thing to note, Marwan. The vast majority of my full-blown diabetics have A1Cs clearly less than 5.6. And here's why. They're watching their diet. They're doing the lifestyle changes they need to do. So even though they have full-blown diabetes, their blood sugars are rarely going over 120. Again, so you need to do a better test. What we recommend is what's called a GTT, glucose tolerance test. You take a glucose blood level, you drink the 75 or 100 grams of glucose, and then you get numbers, time periods afterwards, half an hour, hour, 2 hours, 3 hours. It's far better. And you pick up another 20% of people with disease if you actually also get insulin values as well, fasting or basal insulin, as well as insulin at each one of those testing periods. And some people will say, especially the more academic guys, you can tell them, they'll say, oh no, I get HOMA-IR. HOMA-IR stands for, I can't remember the full acronym. It's an acronym, but they're talking about what they do with HOMA-IR is they look at the ratio of fasting glucose to fasting insulin. And that's very helpful. But I have people with perfect HOMA-IR numbers. When you challenge them, go into full diabetes. So again, full diabetics with totally normal HOMA-IR numbers. Isaac, Afrezza, inhaled insulin, ultra rapid acting, single molecule, fast in and fast out of your system. Yep. And still there is no, yes, that's a major development in the use of insulin, what we call exogenous insulin. Exogenous means insulin coming in from outside the body. Endogenous means insulin inside. Exogenous insulin, they've made a huge amount of progress over the past few years. It's a lot better than it used to be, but it's still not, there's no insulin therapy that's as good as some of the things that are coming out, the SGLT2s, the GLP-1s. I would clearly look at those before I'd look at any type of insulin, exogenous insulin. Alex Katsanos, hey, Dr. Brewer, do you think if your liver is not functioning optimally, your thyroid is probably not functioning optimally either? I haven't seen a whole lot of connections between liver and thyroid, but I will tell you this, there does seem to be some connections between thyroid and cardiovascular disease, clear connection there. Thyroid and diabetes, some probable connections there. Mick, does gout complicate niacin usage? Yes, I'll just leave it at that. Bobby Ocampo, including in the water ball, like, subscribe, bell notification, and share. Thank you, Bobby. Rich D, fasting glucose of 105 for many years. You may have a thing called Dawn syndrome. Dawn syndrome is where, people typically have their lowest blood sugars between midnight and 4 or 5 a.m. Then it starts picking up before we eat. Most folks don't know that. Why does it start picking up before we eat? Because our cortisol, a hormone that causes the liver to slice up those tiny molecules of glycogen and put them out into the bloodstream as sugar. that cortisol starts cranking up about 4 or 5 in the morning. That's why it's called the dawn syndrome. But Rich, if you haven't had a GTT, or even better, an insulin profile, like a Kraft insulin profile, you really don't know what kind of danger you might be in. Jose Fontel, Doc, you keep clearing your throat. I do. I'm on an ACE. So here's the thing. I have several different things going on. And I've shared that many times with the group. When I'm talking about ACE inhibitors, I often find myself clearing my throat and people start getting a good laugh. So why do I take ACE inhibitors? Well, what they have found is that ACE inhibitors have for those of us who have prediabetes or diabetes like myself, it has a huge function in terms of protecting the kidneys and other tissues from the damage that we've been talking about. Now, other docs would say, well, doc, just take an ARB. It's not that, it's the same thing. ARBs are not quite as good. These are both blood pressure medicines. If you haven't heard of ACE inhibitors, they're the ones that end in IL, captopril, lisinopril, benazepril. And I have switched, I've taken all of those three over the years that I've had this. So yep, I'll take the cough. There are a couple of other things that are causing my cough recently. On a permanent basis, I am my mother's son. She has the same issue. I grew up born and raised in Spartanburg, South Carolina, and there's a lot of pine trees where we are, and my mom's actually allergic to pine trees. So she's always doing this, just like me. Now, there are times during the year when I'm not so bad, but if something cranks up, like a seasonal allergy, I'll have it for weeks. Now, here's what happened to me recently. The first week in December, a couple of months ago, I was down here working with the team, and the Delta COVID outbreak was ripping through Mobile. I am pretty sure I got Delta, but I didn't even get tested. I've been fully vaccinated, boosted, and I had a significant upper respiratory infection then. I have been coughing off and on since then. And I've been tested a couple of times. I clearly don't have it now, but I do have that reactive upper airway disease. There's no question. And will I continue to take ACE inhibitors? You betcha. I'll continue to take ACE inhibitors. I'll continue to cough, embarrass myself, make other people uncomfortable, because I don't think it makes people that uncomfortable, especially when they hear what's going on, the reason. So thank you. Dr. Bax, any comment on pioglitazone, role in insulin resistance before onset of hyperglycemia? So Craig, that's a great comment. It used to be like by far the most popular diabetes drug. You may have heard of it, called Actos, A-C-T-O-S. I still use a lot of Actos. Now, why do we use that? If you go back and you look at the newer research around diabetes and body fat, you know, the secret life of a fat cell. Google that, or I've got a couple of videos on it. You can go into my YouTube channel and look at life of a fat cell or secret lives of fat cells. And we talk about this. One of the big issues with, one of the big pathology, anatomical issues that we find with prediabetes and diabetes is you start getting fat within the muscle cell. That appears to be part of the issue driving some of the problem. These, they're called thiazolene diones. This class of drugs, pioglitazone, actually decreases that fat in the muscle cells. Here's the thing, and here's why you bring it up, and here's why I use it a lot. It is the only drug that we know of so far that reliably increases the receptivity of the insulin receptors to insulin. Other things like metformin decrease, they decrease gluconeogenesis, the creation of glucose by the liver. And I personally think metformin also has a gut biome impact as well. But the only drug that we know of that actually improves the receptivity of the insulin receptors is pioglitazone. Thank you, Craig, for bringing it up. I use a lot of it. Bobby Ocampo, and I use it personally, by the way. Bobby Ocampo, what's your opinion on the SGLT2 inhibitors? I am a major fan. When they first came out 5 or 10 years ago, I thought, man, these things look very interesting, but the data was not out there. I just mentioned earlier in the video today, I think it was in the intro to our content, that Farxiga, I think that's dapagliflozin, has come out with some blockbuster research or some blockbuster research has come out using that drug, where it actually showed significant decrease in heart failure. Now remember, I'm going to remind you the comment I made. CVOTs, cardiovascular outcome trials. That's what diabetes drugs go through now. They don't go through so much a trial to see if they help diabetes. They go through trials to see if they help with cardiovascular outcome. And sure enough, 6 months ago, the cardiologists all over the hospitals started talking about Farxiga, heart failure. And by the way, if you're thinking that, well, heart failure doesn't apply to me, 90% of heart failure is also undiagnosed. How about atrial fib? Probably about 90% of atrial fib is undiagnosed. By the way, if you think, well, I know I don't have heart failure because I know I don't have any signs of it. Stage 1, New York stage 1, heart failure, no symptoms at all. Ask your doctor about a thing called ventricular dysfunction or diastolic dysfunction. Vijaya Akar, thank you, Doc. It's been very helpful. Thank you, Vijaya. I appreciate that. Brendan Lenane, lower A1C better? Yeah. When does lower become detrimental? I have not seen a detriment. I've never seen them below 4.8. Never seen them that way. Some Aborigines commonly below 0.9. I've never seen that. That is so interesting. Very interesting. Clean slate, just received a calcium score of over 1,800. Can that be reversed? Most folks will say, no, that's not reversible. I would disagree. I've had not one, but 2 patients who actually demonstrated a decreased calcium score. John Lorscheider and Jerry Kurth. And both of them did videos. So check on YouTube, my videos, reversal of calcium score. Rachel Weinstein, I'm sorry, I don't know how to do the donation. Well, thank you so much for trying, Rachel. Gilbert, if you could flash that up on the super chat, that's how you do that. You can also go to Patreon. We have a Patreon account, and you can go to our website as well if you want to go through that much effort. I appreciate your efforts anyway, Rachel. Thank you. Bobby Ocampo, Ken Berry suggesting C-peptide test. Yes, C-peptide test is basically, it tells us if we made that insulin. It's the other part of the protein that insulin is made from. Rachel Weinstein, what are you recommending for fatty liver? Great question, Rachel. Fatty liver is far more prevalent, just like heart failure, just like prediabetes, just like diabetes, just like some of the other heart failure that we talked about. These are all far more prevalent than people understand and know. And guess what? So is fatty liver. The fatty liver is fairly, fairly simple. It's you do the same thing for fatty liver that you do for the root cause, which is almost always prediabetes. Fatty liver, by the way, has become the #1 cause of cirrhosis. Rachel Weinstein, I'm sorry. Linda McDowell, does diabetes make AFib worse? Yes, it does. And I have AFib. I've got a series of a couple of dozen videos on atrial fib. Atrial fib, just like everything else, the most important things are lifestyle components, getting that weight loss done, dealing with sleep apnea, dealing with blood pressure, those three things actually are key to the frequency on your fibrillation episodes. Here's the other thing to think about. If you have atrial fib, you probably need a different blood thinner besides aspirin, because aspirin is a platelet thinner. And if you have atrial fib, even if you only have it occasionally, that's called paroxysmal atrial fib. And paroxysmal atrial fib increases your chances of having a stroke between 5 and 8 times. So don't mess around with atrial fib. Don't ignore it. I've had plenty of friends, and I've done the same. You know, you feel this funny feeling in your heart, and it like flops. Sometimes it feels like it's flopping, and it's in your chest, a fish flopping. Don't mess around with that. Go ahead, confirm whether or not you have atrial fib. If you do, there's a very simple way to deal with it. It's a medication. They're called the NOACs, the novel oral anticoagulants. You say, oh, that sounds complicated. It's not complicated. You've heard of it. Xarelto is one of them. Eliquis is the one that I prefer. But these are medications that are being used on a regular basis these days. They actually impact the blood clotting mechanism, unlike aspirin, which impacts the platelets. That's why they are indicated for somebody that has atrial fib. Because what happens is the atria are like the larger, smaller chamber up in the beginning part of the heart. The atria has one function. It squeezes, and that helps fill up the ventricle, which really does the hard work. So that's what happens. You know, you hear the lubbed up. That's what's going on. The atrium is contracting, then the ventricle. Now, what happens with atrial fib? The atria is just sitting there quivering instead of actually flexing. There's a part of the atrium called the auricle. It's called auricle because it looks like an ear. And that's what, you know, that's the, I think, Latin term for ear. When you have an atrium that's just doing that, quivering instead of actually beating, you get clots that tend to form in that auricle area. Antiplatelet things like aspirin don't really help decrease that, but the NOACs do, novel oral anticoagulants, Eliquis and Xarelto, and there's a couple of others now. Alex Katsanos, and what about C-peptide test for diabetes? Is that accurate? As we said, it really helps people understand, helps us as docs understand how much endogenous, how much insulin you're actually making, because it doesn't get burned up as quickly. Andrew McDonald, hi doc, are statins dangerous to the muscles? Yes, they can be. Statins have caused death associated with muscle damage. And when you get that muscle damage, it goes to the heart. I mean, it goes to the kidney and can damage the kidneys and kill you. But I take statins and I routine them recommendedly. Why is recommend them routinely? So why do I do that? Something that would that could kill people. Because the other thing kills a lot more people, thousands and thousands more than this. What is the other thing? Plaque, cardiovascular inflammation, what we've been talking about today. Awandro again, AST and ALT, these are liver function studies. They're both low, but the ALT to AST ratio is 1, which I hear is bad. I don't think that's quite as bad as, I'm not worried about that ratio, Awandro. Thank you for asking. Malcolm Smart, I've been wearing a glucose. Let me go down. Okay, so we've got a few more comments, and I'm going to need to leave in a few minutes. So I think we'll try to make the ones that we've got so far. Maxwell Smart. Oh, I'm sorry. I'm showing my age. It's not Maxwell Smart. It's Malcolm. I apologize, Malcolm. I've been wearing a glucose monitor for 2 weeks. By the way, some of you, my generation, may remember Maxwell Smart. I've been wearing a glucose monitor for 2 weeks. Good for you. There's just not nearly enough of that going on, Malcolm. I appreciate you doing it. Levels are looking good, averaging around 90. However, levels dip to the low 60s or lower while sleeping. Any thoughts? Yes. Blood pressure dips to low levels while sleeping. Glucose levels should be dipping to low levels while sleeping, and the 60s are not a problem. That's what we talked about earlier. You may remember that I mentioned between midnight and 4 a.m., that's when we tend to have our lowest blood sugars. It's been demonstrated from research around blood pressure that blood pressure really does need to drop to give it a rest once a day, and that's when it does it. I think we're going to find, although the research has not been done, has not been done yet, blood sugar needs to drop as well. And that's one of the things that I find with my with my pre-diabetics and diabetics that are having trouble. They're just not dropping at night. And that is a problem. Travel with doctor. Hi, doctor. Well, hello. C-peptide is measured to tell the difference between insulin the body produces and insulin that is injected into the body. That is correct. Nothing much else to add. Thanks, Rachel Weinstein and Andrew McDonald. Where do you like to see blood pressure? We used to think it's okay for somebody, especially as they get older, to get these systolics of 130, 140, 160. No, it's not. More recent research has been done indicating that no matter what age you are, if you can get that systolic 120 or less, that's where it needs to be. And what about diastolic? In many ways, many people would say that's more important. I don't know that it's more important, but it's clearly just as important. And the number is not 90. It's not 100. It's not 85. It's 80. So it does need to be 120 over 80 or less. 10 milligrams of Ramipril. Mine sits at 140 over 80. 15 milligrams, it's 115 over 65. In your opinion, I think you meant to say, is it worth the extra 5 milligrams? In my opinion, I would say yes, especially if you don't have symptoms with that. Bobby Ocampo, internet doctor reported metformin blunts muscle growth. Is SGLT2 better for muscle? That comment about, that's a damaging comment. It's so frustrating. It's like the comment about, well, statins cause muscle damage. No, I would recommend use of metformin before I got to the other diabetes drugs. It's a great question though, Bobby, and so many people are doing exactly what you're asking. Oh, I hear a problem. You know what? The SGLT2s, they have problems, and those problems are worse than the problems with metformin. Oscar Bayram, at age 45, I still eat high carbs for breakfast and lunch, but not late in the day. I'm moderately active and healthy. Is this a recipe for future diabetes? We used to say no. And clearly, diabetes is more driven by genetics, epigenetics, things like body fat and lifestyle. But the research has been coming out, especially over the past 5 years, that yes, we didn't think that eating a high carb diet actually drove this problem. It does. But it doesn't drive it as much as age. Age is the number one thing. Genetics and epigenetics, and again, body fat. Those are the three things that really drive diabetes. Bobby Ocampo, internet docs say to avoid sweet fruits if you have fatty liver. I don't recommend people eat apples, guavas, not guavas, mangoes. Apples, mangoes, bananas, things like that. They just have too much glucose. They really do. Eduardo, guys, I was reluctant to come here, and now I know why. Now I think I have claudication and a dozen other conditions. Eduardo, I hope you don't. That I didn't even know existed. I need to see a shrink. Thank you so much for sharing that, Ewandro. Yeah, if you're, that's what we talk about on the channel. Thanks for sharing that. Jan Gregory, statins are anti-inflammatories. The reason you want them is for prevention, but shouldn't they be used in small doses only? Exactly, Jan or John. Jan. I rarely give, I usually use two different statins, Livalo, which maxes out at 2 milligrams, or pitavastatin, or Crestor, or rosuvastatin. I have used the others, but these two are both the best in terms of your genetics and other things. And on rosuvastatin, it's 5 milligrams per day or less. Very, very small doses. Thank you, Jan, for bringing that up. Iwandro, thank you very much, Dr. Brewer. Good stuff. Catch up with you next time. Thank you, Iwandro. Hi, doctor, from Algeria. So we've got two new countries today, Algeria and Kenya. Thank you so much. This is Lamini Kadri, PT Health. How do we test for AFib? That's a problem. I should have brought that up. There's some things. I've got a friend that's had a few symptoms recently, and I showed him several things. The Apple Watch cardio, you got to get the cardio version. That does it. But there have been things out there for years. I diagnosed my own about 5 or 6 years ago with it's a $70 apparatus. You put your thumbs on these little plates. It hooks to your iPhone, and it does it gives you the EKG reading. Not a full-blown EKG, just that one lead, but that's enough to give you that rhythm strip. So 2 more comments, and we're going to finish up. Thanks for the session. Terrific. I'll be sharing it. So I think the last one we had was Vaughn Telecom. Ultrasound showed some hardening in my arteries. Prescribed me with 10 milligrams of Crestor. And do I need it? It says my LDL should be about 1.4. So there you go. Let's see if we can comment on this. If ultrasound showed hardening, you've got significant problems. Be afraid, be very afraid, but deal with it because there's plenty you can do. Prescribe me with 10 milligram Crestor. I do recommend a statin if you have plaque for reasons that I mentioned earlier. Do you need 10 milligrams? Probably not. It says my LDL should be 1.4. I don't know I'm over in the US, so I use different units, but I'm not worried about LDL anyway. I'm worried about inflammation. Very, very different issue. So again, we've got a lot of folks here. We've had a lot of folks share super chats. We really appreciate that. A lot of information getting out there. Thank you so much for your interest.